Right, can I confirm this is a case you've already looked at?
Yes, it is.
Okay, this is your lung case. Can you tell me how you'd assess this gentleman preoperatively?
I'll visit the patient on the ward, and I would have a look through his medical notes to get a history of, other medical problems that he may have in addition to his lung cancer. And I would also have a look at any pre-op investigations that had been done already.
Okay.
And then I would go and visit the patient himself and take a history, including a full anaesthetic history, as you would for any other anaesthetic.
What would you look at particularly for this gentleman? In the history, for starters.
In the history, I'd like to take a history of his COPD. So how long he's had it, what sort of things he manages it with, what his symptoms are like, and whether he has an infection or anything at the moment.
So what sort of symptoms in particular?
So I'd ask him about breathlessness and maybe whether he has a cough and a wheeze, and what he's able to do day to day when he's well, I suppose.
Right. And what investigation would help you decide about his COPD?
Well, he would have had some pulmonary function tests done already in the pre-assessment clinic, so I would have a look at those.
Right, and you've seen those already, haven't you? What did you think of them?
Well, it shows that his FEV1 is about 70%, which is sort of moderate obstruction.
What different severities are there for COPD?
There's mild, moderate and severe. I think there's a severely severe.
What's severely severe?
At the very extreme of very low FEV1, I think.
Okay. What else would you like to know about his lung function before you proceed to operation?
So his FEV1, also his FVC, that's quite useful. That has been used before to help predict maybe whether they might need intensive care afterwards, after resection.
What else will help you predict how they'll be later after the operation?
We need to know how much lung is going to be removed so that we can, well, generally the surgeons work it out and let us know, but...
Do you know how they work it out?
It's based on the number of lung segments that they're going to be removing, and they use it's in a fraction. I don't know it off the top of my head, but I could check it up if I needed to work it out.
So if we say, for argument's sake, this gentleman's having his left lung resected, and that's roughly half the segments.
Yeah.
Do you know how many segments there are?
There's 19 or 20.
Yeah, 19. So he's having 9 of them taken out. What would you predict for his post-operative lung function?
So it would be roughly half of what it is now. So it's about 70%, so about 35% of his predicted, which might mean he's quite highly likely to be quite breathless afterwards and may need to be in sort of intensive care for a while.
Right, he might do. Can you tell me a little bit about the X-ray?
Well, I would check that it's the correct patient.
It's the correct patient,
and I would check all the demographics and that it's AP and it looks like an erect film. So starting off with sort of adequacy of the X-ray, you can see all the relevant areas of the lung fields. It doesn't look to be too rotated, and it's got reasonable penetration because you can see.
Are there any particular things that jump out at you?
Well, there's this area here. There's the rounded, which is probably the cancer, which they're going to be resecting. There's a little bit of air under the diaphragm here, which is where the stomach is, so he's probably just got some air in his stomach.
Okay, so
the rest of it looks okay.
Right. What else do you want to know before you proceed to operation?
I need to know...
Any other investigations you want for this gentleman?
An arterial blood gas would be quite helpful.
Baseline gas, yeah?
Yeah, just to see what his PO2 is and whether he's a CO2 retainer. Other things, I'd obviously have a look through his usual investigations, like his full blood count, his using to check what his renal function is.
Did you notice anything abnormal in any of those?
He had a mild anemia on his full blood count. His haemoglobin was about 12.
Why might that be?
Well, he has a chronic underlying lung condition, and also now he has cancer.
Right.
So it's probably a
What
chronic.
other problems, particular anaesthetic problems, might cancer lead to?
Oh, Eaton-Lambert syndrome is associated with some lung cancers,
What's that?
It's a presynaptic. It's an autoimmune condition which is associated with impaired presynaptic release of acetylcholine, and it's autoimmune destruction of the calcium channels in the presynaptic membrane, and that's relevant because it has an implication for us on which non-depolarizer or depolarizer muscle relaxants we're going to be using.
Yeah.
And also you need to think about whether you're going to send them to intensive care afterwards for ventilation.
And you probably will. Right, how are you going to go about anaesthetising this gentleman?
Okay, so I would bring the patient down to theatre.
In this oral, the candidate's knowledge was superficial and did not focus on the clinically important aspects of the case. Information about further testing and investigations came out with undue prompting. Therefore, an inadequate amount of material was covered in the time available. This is an example of an oral with a borderline score, each examiner scoring the candidate a 1.